I am going to discuss about nutrition care. What is nutrition care? Do you ever heard about this concept? Do you have any idea about this concept? Let's start with the nutrition care process. This process provides the best quality of care. We must remain aware and in some ways be a bit of a detective. Nutrition care process provides a structured approach that can be personalized to meet the needs of all your patients and clients. The framework of a nutrition care process supports decision making and critical thinking, ensuring the efficient and effective care is provided to your patient. When providing the utmost care and lots of love to your patients, there are always steps and processes to guide and ensure the quantity. The purpose of providing the nutrition care is to restore the state of nutritional balance by influencing the certain factors that are contributing to the imbalance or altered state of nutritional status. Actually, nutrition care process is a problem solving process that professionals use as a standardized problem solving methods. Professionals use the nutrition care process to think analytically and make decisions to resolve the nutrition affiliated issues while providing safe, high quality nutrition care. Nutrition care process involved four different steps to support the initial assessment all the way through planning the follow-up care. These four steps include nutritional assessment. Second one is nutrition diagnosis. Third step is nutrition intervention. And fourth step is nutrition monitoring and evaluation. You can see here an abbreviation which is A.D.I.M.E. This is the abbreviation of different steps of nutrition care process. A stands for assessment, D stands for diagnosis, and I stands for intervention, M stands for monitoring, and finally E stands for evaluation. A.D.I.M.E. is the abbreviation of steps of nutritional care process. Now let's start with its first step, which is nutritional assessment. Nutrition assessment is an in-depth evaluation of both type of the data, which is objective type of data and subjective type of data related to the individual's food and nutrient intake, individual's lifestyle and medical history. Once the data on an individual is collected and organized, the dietitianist can assess and evaluate the nutritional status of that individual. Then assessment leads to a plan of care or intervention designed to help the individual either maintain the assessed status or attain a healthier status. Nutritional assessment is a systematic approach to collect, classify, and synthesize important and relevant data needed to identify nutrition related problems and their causes. This also includes reassessment for comparing and re-evaluating the data from the previous interaction to the next, and collection of new data that may lead to new or revised nutrition diagnosis based on the client's status or situation. Nutrition assessment is an ongoing process that involves initial data collection and continual reassessment and analysis of the client's status compared to the accepted standards and recommendations. Nutritional assessment data falls into four different categories. First is anthropometric, second is biochemical, clinical, and dietary assessment methods. First, we discuss about the anthropometric measurements. Anthropometrics are the objective measurements of the body muscles and fat. They are used to compare individuals, to compare growth in the young, and to assess the weight loss or weight gain in the individuals. Weight and height are the most frequently used anthropometric measurements, and skin fold measurements of the several areas of the body are also taken. Tables had been developed to compare the weight and height in order to provide a reference for individuals' health status. Some researchers indicated that lowest mortality rates were associated with below average weight, and the phrase which is desirable weight replaced with ideal body weight in the title of the height and weight tables. To further characterize an individual's height and weight, tables also include body frame size, which can be estimated in many different ways. An easy way is to wrap the thumb and forefingers of the non-dominant hand around the wrist of the dominant hand. If the thumb and forefingers meet, the frame is medium. If the fingers do not meet, the frame is large. And if they overlap, if the fingers are overlap, the frame is small. Determining the frame size is an attempt at attributing weight to specific body compartments. Frame size identifies an individual's relative to the bone size, but does not differentiate muscle mass from the body fat, because it is the muscle mass that is metabolically active and the body fat that is associated with disease states. BMI, which is the abbreviation of body mass index, is used to estimate the body fat mass. BMI is derived from an equation using the weight and height, weight over height square. To estimate body fat, skin fold measurements can be made using skin fold calipers. Tricep and subscapsular skin folds are measured. Measurements can be compared to the reference data and previous measurements of the individual if those measurements were available. Accurate measuring takes the practice and comparison measurements are most reliable if done by the same technician each time. To estimate desirable body weight, equations have been developed. Estimating desirable body weight as well as calorie and protein needs. Calorie needs are determined by the height, weight, and age of an individual, which determine an estimate of daily needs. Harris-Benedict equation is frequently used to measure the caloric requirement of the individual. But there are quicker methods to estimate the needs using just height and weight. Opinions and methods vary on how to estimate the calories needs for the obese. Body fat is less metabolically active and requires fewer calories for support than muscle mass. If an individual's current body weight is more than 125% of the desirable body weight for the individual's height and age, then using body weight to estimate the calories needs usually leads to an overestimation of those needs. Next element of the assessment is biochemical data. Laboratory tests based on blood and urine can be very important indicators of nutritional status, but they are influenced by non-nutritional factors as well. Lab results can be altered by the medications, individuals' hydration status, and disease state or other metabolic processes such as stress. Next element of assessment is clinical data. Clinical data provides information about individuals' medical history, including acute and chronic illness and diagnostic procedures, therapies, and treatments that may increase nutrient needs or induce the malabsorption. Current medications need to be documented, and both prescription drugs and over-the-counter drugs, such as laxatives and analgesics, must be included in the analysis. Vitamins, minerals, and herbal preparations also need to be reviewed. Physical signs of malnutrition can be documented during the nutrition interview and are an important part of the assessment process. The fourth element of the assessment is dietary data. There are many ways to document dietary intake. Accuracy of the data is frequently challenged since both questioning and observing can impact the actual intake. During a nutrition interview, the dietitian may ask what the individual ate during the previous 24 hours, beginning with the last item eaten. Prior to the interview, dietitian can train the individuals on completing a food diary, and they can request that the record be kept for either 3 days or 1 week or 2 weeks. Documentation include portion sizes and how the food was prepared. Portion sizes was very important. Documentation should always include the portion sizes consumed and how the food was prepared. Brand names or restaurants where the food was eaten can assist in assessing the detail of the intake. Estimating portion sizes is very difficult, and requesting that every food be measured or weighed is time consuming and can be impractical. Food models and photographs of foods are used to assist in recalling the portion sizes of the food. In a metabolic study where accuracy in the quantity of what was eaten is imperative, the researcher may ask the individual to prepare the double portion of everything that is eaten. One portion to be eaten and one portion to be saved. Food frequency questionnaires are used to gather the information on how often a specific food or specific type of the category of the food is eaten. The food guide pyramid suggests portion sizes and the number of servings from each food group to be consumed on a daily basis, and can also be used as a reference to evaluate the dietary intakes. Exchange lists can also be used to provide the alternatives. During the nutrition interview, data collection will include questions about the individual's lifestyle, including the number of meals eaten daily, when they are eaten and where they are eaten, and who prepared the meals. Information about allergies, food intolerances, and food avoidances, as well as caffeine and alcohol use, should be collected. Exercise frequency and occupation help to identify the need of increased calories. Asking about the economics of the individual or family and about the use and type of the kitchen equipment can assist in the development of a plan of care. Dental and oral health also impact the nutritional assessment, as well as information about gastrointestinal health, such as problems with constipation, gas, diarrhea, vomiting, frequent heartburn, and inflammatory bowel syndrome. Uh, is the process of evaluating what people eat by using one or several intake indicators. It is the best approach for identifying nutrients that are likely to be under or over consumed by the individual or by the group of interest. It also can be used to identify food patterns and food preferences of the individual and group. Dietary status is related to the but not necessarily reflective of the nutritional status. Nutritional status is a more comprehensive term referring to the health status which is affected by the nutrition. It is measured not only by assessing the dietary status but also by the anthropometric, biochemical, and clinical measurements because dietary methods are less invasive, somewhat easier to obtain than other physiological measures, and do not require medical training. They often are used initially for assessing the nutritional inadequacy or excess. Physiological measurements are then used to confirm and corroborate dietary intake evaluation and to arrive at definitive assessment of nutritional status. To assess the dietary intake, food composition tables for translating foods consumed into nutrients and a reference against which dietary intake may be compared are needed. These tools have been updated and refined periodically, and appropriate ways for applying them to assessment tasks are steadily clarified. The various methods for assessing the dietary intake are used. All assessment methods fail to capture actual energy intake very precisely and probably intakes of nutrients as well. Dietary intake is sometimes assessed by an objective observer rather than by the eaters themselves. For example, intake of a hospitalized patient is assessed from the measured differences of food served to a patient, less any unconsumed amounts. Such objective methods have the advantages of being less subject to reporting biases than those that rely on recall. More objective methods are very time consuming, costly, cannot usually be employed to assess typical intake, and fail to record all intake. They may not reflect what people really eat. People may eat differently when they know that they are being observed. For these reasons, most commonly used dietary assessment methods rely on eaters' self-reported intakes. Most methods such as 24-hour recalls, food records, and dietary methods underreported actual energy intake by at least 20%. Underreporting errors are even higher in certain groups, such as obese women and elderly people. Intakes obtained using food frequency questionnaires have other shortcomings. This method presents the respondents with a food list. These prompts may decrease forgetting. Food frequency questionnaires are too imprecise to estimate individual intake quantitatively. Nutrient intakes from food frequency questionnaires usually are overestimated. They usually are adjusted to obtain more accurate estimates of usual intakes. Measures of usual energy intakes for accurate groups specified by gender and age, obtained by other methods or from estimates of energy, are used to adjust them. Retrospective methods that rely on memory are subject to forgetting bias. Prospective methods which rely on reporting food intakes immediately or shortly after eating are more subject to alternations in intake due to the individual's awareness that intake is being recorded by the individual. There are several dietary assessment methods are used frequently which reflect the usual intake of individual. First method of dietary assessment is retrospective methods, which is 24-hour recall. Respondent recalls all the foods and beverages consumed in a given 24 hours period and reports them to a interviewer who probes to get additional details on portion sizes, frequency, and forgotten items. Positive aspects include low respondent burden, ease in administration, and minimization of biases associated with altering food intake because of knowledge that one is being observed. Negative aspects of the method include forgetting, misreporting, need for a trained observer to administer, need for the several days of intakes to obtain the estimate of usual diet, and cost associated with computerized analysis of record. Telephone recall is another dietary assessment method which can also be used by the replacement of 24-hour recalls. The respondent in this method, respondent is contacted or instructed in advance and given instructions about estimating portion sizes and other details. Then the respondent is called by telephone and asked to report dietary intake over the past 24 hours. Props and techniques are usually standardized to minimize the reporting errors. Positive aspects of the methods include those listed: ability to obtain the representative random days of intake and decreased cost of administration. Negative aspects include inability to obtain the interviews from those without telephones and for those who find telephones difficult to use, and errors in reporting portion sizes. Food frequency questionnaire is also used as an dietary assessment method in which respondent chooses from a list of different foods or food groups usually eaten over the past month or year, the number and types of foods, and whether the portion sizes are specified varies from one questionnaire to another questionnaire. Positive aspects of the method include ease of the administration, low expense, less forgetting because of the prompts furnished by the food list, somewhat more of an estimate of usual intake, and low cost of data analysis. Negative aspects of method include incomplete reporting of items not included in food list, over-reporting, incomplete or inaccurate response, inaccurate translation of food and food groups to nutrients, and imprecise estimates of nutrient intake. Dietary history can also be used as a method of dietary assessment. Respondents reports all foods and beverages consumed on a usual day to a trained interviewer. The interviewer then probes further on the frequency, amount, and portion sizes consumed. Diet diaries are sometimes used to assist respondents in recalling their food intakes. Positive aspects of the method are that respondents' burden is low and complete intakes are provided. Negative include high cost, need for trained interviews, and lack of standardization. Prospective methods, weighted food records are another methods used as a dietary assessment method. After being instructed, respondents weighs all food and drinks consumed on a small weighing scale and reports it on a records that is kept as close to the time of consumption as possible. If observers are available, they can carry out the weighing themselves. And positive aspects of the method are lack of forgetting bias and ability to obtain random days of intake. Negative include high respondent burden, refusal to record intakes, need for an expert observer to review and clarify intakes reported, tendency of respondents to alter food intakes when they know that they are under observation, and cost of data analysis. In food diaries, the respondents records all foods consumed in household measures, usually without measuring them, or only measuring the foods that are particularly difficult to estimate. Positive aspects are same as food records, but respondents' burden is less. Negative aspects are that more errors in estimation of the portion sizes may occur. In duplicate portion analysis, an observer takes duplicate portions of all food consumed by the individual and weighs or measures them. These may also be chemically analyzed. Positive aspects are similar to the food records, but negative aspects are lack of respondents' cooperation, need for trained observers, cost of food analysis, and inability to obtain the estimate of usual intake. Indirect observation by the trained observers. Observers records or watches the food intake in a controlled or highly supervised environment in which it is possible to videotape or directly observe the food intake. Positive aspects of the methods are that they do not rely on respondents' burden. Negative aspects are that the methods are usually too imprecise for obtaining the valid estimates of individual intake. Many foods and beverages are fortified with nutrients, and a substantial portion of the population takes nutrient supplements on a regular basis. These nutrient sources contributes a substantial amount of vitamins and minerals. Nutrient intake from all sources, including foods and beverages, fortified foods, and nutrient supplements, must be included in all dietary assessment. If only food sources are required, this fact should be noted. Always use the complete food composition tables. Once food intakes are obtained, these must be translated into nutrients using food, beverages, and supplement composition tables. Accurate nutrient intakes can be obtained if up-to-date and complete food composition tables are available. The composition of fortified foods, nutrient supplementation, and beverages must be included, and tables must be complete for all nutrients and other bioactive substances of the interest. Second step of nutrition care process is diagnosis, nutrition diagnosis. Nutrition diagnosis is a statement that summarizes the issue that a dietitian is attempting to resolve. This is also sometimes known as a PES statement. P stands for problem, E for etiology, and S for signs and symptoms. A nutrition diagnosis differs from a medical diagnosis in that a nutrition diagnosis is created only by a registered dietitian, and a nutrition diagnosis can reflect an intake, clinical, or behavioral issues. A nutrition diagnosis is used by the dietitian to prioritize nutrition care, create the nutrition interventions, and monitor the success of those interventions. Nutrition diagnosis identifies nutrition problems that the nutrition professionals or dietitian is responsible for treating. From the data collected and analyzed in the nutrition assessment, practitioners can identify what the nutrition diagnoses are. Once diagnoses are understood, recommendations can be presented to a patient. A patient can work with a dietitian to set the goals to move towards for the betterment of their health. When creating a nutrition diagnosis statement, specific nutrition diagnostic terms and the etiology, signs, and symptoms will be identified. Nutrition diagnosis can reflect an intake, clinical, and behavioral issues. I will give you an example. For example, individual is coming at your clinic who has been newly diagnosed with celiac disease. You will assess her nutrient intake and her knowledge of celiac disease and gluten containing foods and create a nutrition diagnosis based on this information. You must be summarize the issue and attempting to resolve that issue. There are three parts to a nutrition diagnosis statement. The problem or nutrition diagnosis describes alterations in the client's status. Etiology is a factor that contributes to a problem, including situational, developmental, cultural, and environmental factors. Signs and symptoms supporting the existence of the nutrition diagnosis. Nutrition diagnosis should be clear and concise and always specific to the patient or client well-being treated. The first step in creating a PES statement is to complete a nutrition assessment. Nutrition assessment is all about gathering of information from a patient. When patient comes to the clinic for her outpatient appointment, you will complete an assessment. The information that she provides will likely indicate what nutrition problem she is experiencing. Dietitian must use open-ended questions or questions that require more than a yes or no answers to engage their patients and get more detailed information. For example, if you ask your patient if she knows what food contains gluten, she will say yes. But if you ask her to list gluten containing foods, she might admit that she only knows a few. After determining what nutrition problems are impacting a patient's quality of life and health, you would find out the etiology or cause of this problem. In this case, the etiology is likely that she has been recently diagnosed with a new and unknown disease state. Other example of etiology may be an inability to purchase gluten-free items or a lack of motivation to create a lifestyle changes. You would identify the signs and symptoms associated with her nutrition problems. Signs are the objective or measurable data. This includes measured values and time frames, and symptoms are subjective or reported data. A patient will list their signs and symptoms. First thing, the patient may tell you that the reason she came for outpatient nutrition counseling was because she feels lethargic, weak, has had weight loss, and has been having diarrhea 3 times per day. These signs and symptoms can be used to support the nutrition problems in your PES statement. Type of nutrition care plan is nutrition intervention. Nutrition intervention is a planned action designed with the intent of changing a nutrition related behavior, risk factor, environmental condition, or aspect of health status to resolve or improve the identified nutrition diagnosis or nutrition problems. Nutrition interventions are selected and tailored to the client needs by planning and implementing appropriate interventions. The nutrition diagnosis and its etiology drive the selection of a nutrition intervention. The nutrition intervention is typically directed towards resolving the nutrition diagnosis by altering or eliminating the nutrition etiology. It is directed at relieving the signs and symptoms of the nutrition problems. Nutrition intervention goals developed collaboratively with the client, provide the basis for monitoring progress and measuring the outcomes. Nutrition intervention is accomplished in two distinct and interrelated steps: planning and implementing. Planning the nutrition intervention involves prioritizing nutrition interventions based on impact and available resources, collaborating with the client to identify goals of the intervention for each diagnosis, writing a nutrition prescription based on a client's customized recommended dietary intake of energy and selected food and nutrients based on current reference standards and dietary guidelines and a client's health condition and nutrition diagnosis. Selecting specific nutrition intervention strategies that are focused on the etiology of the problem and that are known to be effective based on best current knowledge and evidence. Defining the time and frequency of care, including intensity, duration, and follow-up. And in implementation, it is the action phase and involves collaborating with the client to carry out the plan of care, communicating the nutrition care plan, modifying the plan of care as needed, following up and verifying that the plan is being implemented, revising strategies based on changes in condition or response to intervention. Terminology for nutrition intervention is organized in four different domains. First is food and nutrient delivery, individualized approach for food provision. Second domain is nutrition education, a formal process to instruct or train a patient in a skill or to improve the knowledge to help the patient voluntarily manage or modify the foods, nutrition, or physical activity choice, and behavior to maintain or improve the health. Third domain is nutrition counseling, a supportive process characterized by a collaborative counselor patient relationship to establish food, nutrition, and physical activities, priorities, goals, and individualized action plans that acknowledge and foster responsibilities for self care to treat an existing condition and promote health. And the fourth last domain is coordination of nutrition care. Consultation with referral to or coordination of nutrition care with other healthcare providers, institutions, or agencies that can assist in treating or managing the nutrition related problems. The last step of nutrition care process is nutrition monitoring and evaluation. Nutrition monitoring and evaluation identifies outcomes, indicators relevant to the diagnosis and nutrition intervention plans and goals. During the first interaction, appropriate outcomes indicators are selected to be monitored and evaluated at the next interaction. During subsequent interactions, these outcomes are used to demonstrate the amount of progress made and whether the goals or expected outcomes are being met. Factors to consider when selecting indicators are the medical diagnosis, healthcare outcomes, client goals, nutrition quality management goals, practice setting, client population, and disease state or severity. This step consists of three actions: monitoring, measuring, and evaluating the changes in nutrition care indicators. Dietitian monitor by providing the evidence that the nutrition intervention is or is not changing the client's behavior or status. They measure outcomes by gathering the data for indicators. Nutrition and dietetic practitioners compare the current findings with previous status, nutrition intervention goals, and reference standards, evaluate the overall impact of the nutrition intervention on the client's nutrition diagnosis and health outcomes. The use of standardized indicators and criteria increases the validity and reliability of outcomes. Nutrition and dietetic practitioners are encouraged to use the tables, new, active, resolved, or discontinued, to communicate the states of each nutrition diagnosis. In monitoring progress, check patients' understanding and compliance with nutrition intervention. Determine whether the intervention is being implemented as prescribed. Identify other positive and negative outcomes. Gather information indicating the reasons for lack of progress. Support conclusions with evidence. And in measuring the outcomes, select the nutrition care indicators to measure the desired outcomes. Use standardized nutrition care indicators to increase the validity and reliability of measurements of change. And in evaluating the outcomes, compare monitoring data with the nutrition goals or reference standard to assess programs progress and determine future action. Evaluate impact of sum of all interventions on overall patient's health outcome. Care process is a systematic approach to providing high quality nutrition care while using a universal language. It is a set up as four parts and is represented as a circle due to its continuous nature. A.D.I.M.E, used for representing the four steps, stands for assessment, diagnosis, intervention, and monitoring and evaluation. These steps help dietitian understand the needs of the patient and help to plan the approach for caring for the patient. The nutrition care process allows healthcare professionals to communicate amongst each other in a universal language understood by all. A state of nutritional balance. by influencing whatever factors are contributing to the imbalance or altered state of nutritional status.